and we're in for a real treat today. Thank you so much, Bob.
So nice. First, it is so great to be here. Thanks for coming on a rainy day to sit in a room and think about something much more interesting than anything else, which is healthcare. And thank you, Stanford, for putting this on. This is an amazing get-together and conference, and I'm grateful to Freeman Sproglia and Stanford Health Policy and the School of Medicine for doing this. It's great that you bring people together to talk and think and learn and make it high quality. So thank you. I'll do my best not to lower and disappoint the academic quality that is here. What I thought I would do today is do two things. Talk a bit about the last 5.5 years, what's happened since the Affordable Care Act has passed and we've gone through this massive period of change and angst in the country, and then spend most of the time talking about what we can do to make healthcare better, faster, and get on with it, which hopefully we'll do in 25 days after we stop this campaign. And so that's how we're going to kind of spend the time together. And then Lauren is we're going to sit down and you're going to grill me, I guess. Yeah. And then we'll do questions. And so we'll make sure there's time for that. All right. March 23rd, 2010. I would clap, but what I thought I'd start with is just a bit of the history, because it's important to predict the future. The Affordable Care Act took a little longer than we expected to pass. During the transition, we mapped out the first 100 days, and we thought that we would pass the ACA, or PPACA, through both houses of Congress around Memorial Day, have a signing ceremony in June, and then have a summer of jobs. We were a year off on our planning, and we had 60 Democrats in the Senate and a huge majority in the House, and had pre-wired the Finance Committee with Liz Fowler writing a white paper the year before and doing all the policy work. And so it was going to be pretty straightforward, we thought, to pass healthcare reform through, with a popular president through Congress. You saw what happened. It took a little longer. When the president signed this, it was actually after Scott Brown, if you recall, got Kennedy's seat. We had these reconciliation, everything you can imagine that could throw a monkey wrench in did. And when you see the signature, what you see is actually the impact of 23 pens used to sign the law, which is what happens when the president passes a law, is that he or she has a bin of pens, and each little millimeter there is a pen that was given to a different member of the House or the Senate to thank them for their support, which goes to kind of how hard it is to pass policy in America, is you need 23 pens to do it. So what's happened? Despite the single worst launch of a website in the history of the internet, and then the heroic work of perhaps the greatest American public servant that if you don't know, you should name Todd Park, who fixed it in 6 weeks with 12 people. Today, 20 million people have access to healthcare. 13 million through private plans, 7 million through Medicaid. I think that post this election, we're going to see Medicaid continue to get expanded across the country. It makes too much sense for hospitals to push their Republican governors to do it. So I expect we'll see more. The other thing that's been an interesting surprise, and if you read critiques of the ACA, you might be confused by people not speaking with all facts. The CBO predicted more people in the exchanges than there are today because they predicted a lot of employer dropping. One of the big worries was people who love their employer plans, despite perhaps not understanding them, would be dropped into exchanges and then have to buy new plans. And there's actually been a net gain adjusted for job growth of employer-sponsored insurance. So that just hasn't occurred. And so more people today have healthcare through their employer than have ever before in America, adjusted for the job growth that we've had since the recession, which is an interesting surprise. We did not expect that. On the cost side, there was predictions that this would be massively inflationary. And what we can say over the last 5 years is that costs have grown less than expected. And there's a lot of reasons to that and a lot of work that's been done on that. But the ACA has not been a propellant of inflation that many expected. And on the quality side, I read a paper that was so wrong a couple years ago in Health Affairs, talking about how the readmissions penalties were actually a homeopathic medication, and that hospitals should just ignore them because there's plenty of space inside of them, and why wouldn't you readmit everybody again? It's actually higher margin when the patient comes back with the same diagnosis to get treated again. They're there for fewer days. That this shouldn't work at all. I was wrong, totally wrong. Hospitals have actually spent a lot more time and effort lowering readmissions than we would have expected based upon the magnitude of the penalty There's about 150,000 fewer admissions every year now, thanks to sort of the lowering of that. And what's great is that it's not that hard to do. If you schedule a patient an appointment within a week with their physician and give them the right meds, that averts a lot of the complications. But it's worked better than we expected. And to the extent that you believe that Medicare Advantage stars equates to quality, we can say for sure more people are in Medicare 4 and 5-star plans, which is potentially another good benefit to quality. This is a chart that shows you, and I feel embarrassed to show this to economists because you can draw this from memory, but healthcare costs over the last period have grown slower, and we had a big step up in 2014, and that's predominantly driven by the fact that there's 20 million more people who now can go to the doctor 3 times for free to get preventative care, and obviously with insurance, much more affordably than before. The question's what happens next. You expect a one-time step up. CBO predicted this. We all thought it would happen. But what will happen next? And there's reasons to be hopeful and worried, depending on where you sit, for what will happen. Drug costs continue to be a problem. A bigger problem, I think, is job growth, and we'll talk about that more later. But what will happen to this trend? I think what you have to take away from this is the fact that no matter how you average over what period you choose, healthcare continues to grow faster than the U.S. economy, and that is a problem. Healthcare is $18,000 for a family of 4 to buy a premium. That's about the price of a Corolla. And so the idea that you'd effectively buy a new car every year doesn't feel like we're getting the right amount of cost pressure in the system that we need. And so I think that's going to be the most fundamental problem going forward. There's an election. I think nothing will happen, no matter who wins on healthcare. If Hillary Clinton wins, I think her priorities are actually going to be totally separate from Affordable Care Act tweaks. I think she'll work on K-12 education and bring up the Nixon approach of universal pre-K, and then work on infrastructure spending, and then perhaps do something internationally. The odds that she wants to relive 1993, when she last did it, and harken back to charts that showed a complicated healthcare system, which remains complicated, it seems implausible to me. And if she doesn't win, I don't think we'll do it either. God. I can't bring myself to comment on because I don't think that. Wait, I'll stop. All right, there's nothing good that will come from the next sentence. All right, policy opportunities. Here's what we need to do. Period. There's 4, I think, major things that we should all pay attention to make healthcare work better, faster in America. And the first one is we need to make these adolescent exchanges, grow into adults and be stable and work better. And there's a lot you can do to do it. And it actually isn't like super complicated policy that requires original thought. We have Part D and MA to go back to, and we can do what we did there that worked. Number 2, and I realize that there's some hospital leaders in the room, and I salute you. You've done many things right, including get market power. We need to figure out how to make the demand side of the equation do more to balance the supply side, and I am sheepish because I'm going to say things that piss you off. Third thing is we need to design the new payment models correctly. Today is Christmas. CMS released the long-awaited and beautifully written macro rule. I'm through about 400 pages of the 2,800 pages. You can skip the last 1,200 because they're just comments and go to the end where they talk about how they're going to interpret them. But there's some really, really thoughtful and good stuff in here. It's a better rule than I expected. It's massively important, and I get to tell you a little bit about it. But I'm really excited about the APMs, the payment models that we're going to have. I think they work better than people thought, particularly for independent doctors. And the last thing we have to do, and we need to do it sooner than we might think and more aggressively than we want to, is save money. Healthcare remains massively inefficient, and we've made a bunch of steps in the right general direction through incentive realignment, but it's insanely unaffordable. I got a bill from a provider in Palo Alto a couple weeks ago for my child who went to the emergency room for the Tylenol that she took for $52, which seems like a little more than I expected for the Tylenol. I offered to give her the Tylenol I had in my backpack, but was told I couldn't because of the safety of the hospital. And then I said I'm a doctor and I washed my hands and they still wouldn't let me. So I bought $52 worth of one Tylenol. All right, how do we make exchanges work better? Those of you who have been conscious have noticed that there's been some angst over the exchanges. Many states have small ones. Many health plans have complained that they haven't made as much money as they'd planned in these exchanges. Aetna said, we can't figure out how to do direct-to-consumer, we're out of here. Oscar has lost, I think, $260 million and has decided that Arizona is a good market for them to expand to, and so they've had a lot of issues in New York. Cover California is the only one that's worked well. So to that, we can thank Governor Schwarzenegger, who courageously passed through a Republican legislature in California actual authority to build an exchange and then build it right. We do a bunch of things differently in California that the rest of the country needs to copy, like have large bidding regions, have bidding and not let everybody in, do marketing and outreach to young, healthy people, have a website that sucks less than almost every other. And so it's not the greatest, but it's pretty good. And so we've done it better than any other state. And obviously having 1.7 million people in it makes it infinitely more attractive to both compete in as a payer and much more stable to price. And so how do we make the rest of the country look more like California? These are the 4 things that you should do. The 5th thing is the thing you need to do, but I put it below the line because it's not going to pass through Congress in the future that I can foresee. The first one is extend reinsurance and risk corridors. In the ACA, we had three policies to stabilize the markets. They're straightforward. Risk adjustment, so you can't cherry pick young, healthy people. Got that. Number 2, reinsurance, so you don't really know who's coming in. You're sure the sick people come in, but you're not really sure how many and how sick. And then the third one is risk corridors. Risk corridors is a policy that works in MA and Part D that protects you from kind of unexpected chronic disease costs. We thought when we wrote this law that these were all mandatory appropriations. It so happens that 2 of them, well, reinsurance was. Risk corridors wasn't. And so it got stripped out in the CR to fund the government in December of 2014 by Marco Rubio and others. And that was $800 million of support to markets that went away. In many states, all the losses could have been covered if risk corridor payments came in. Health plans all price premiums with a perception that it would come in. And HHS has done a bunch of things to try to figure out clever ways to fund it, but has not succeeded yet. It's a policy that certainly has worked well in other government programs, and it would be one that would be useful to put back in. I have some cautious optimism that in the lame duck session of this Congress that they may actually extend these programs. They're not very expensive in the big scheme of government spending, so they could be offset. The second one is one where the economic policy team and the political team had spirited discussions about what's the ratio between pricing of young to old people. Prior to the ACA in America, on average, the ratio from what a young, healthy person would pay to what an old, near Medicare person would pay was 7.5 to 1, which meant that young people could buy very inexpensive healthcare insurance, and if you were 63, forget about it. It was going to be super expensive. And that was viewed as regressive and not desirable, and so we compressed that ratio to a 3 to 1 ratio. And that is the benefit of giving pre-Medicare older people a really good deal on their health insurance. It's a cross-subsidization. The challenge is that no matter what, it makes health insurance much more expensive for the 27-year-old healthy person that wants to come into the market. And so you could play with that ratio, and when you do that, if you go to 4 to 1 or 5 to 1, it would make premiums quite a bit cheaper for young people and be helpful in many areas of bringing them into the market. The downside of that is that if you're older, you get screwed. And so you might have to apply some extra subsidy for older people to make sure that you don't get an imbalance of taking coverage away from those that most need it. And again, this is a policy that wouldn't cost much, and it might be bipartisan. The third one is something that we've learned from California and from Medicaid in nearly every state that does manage Medicaid, is you don't bid by county. Right now in the HHS exchange, and plans can decide which counties they want to offer their health plan in. And it doesn't take a business genius to figure out that you offer your plan in counties where you have better mix of risk and people and a network that allows you to make money. And so not surprisingly, many rural areas have little to no competition. And so you could make bigger bidding regions, which would make it better for plans to want to compete. You could group San Francisco with the Central Valley. You could do a lot of things to make it work better. California really did a good job on this. And actually, most states for Medicaid managed care have done this well too. So that's a relatively straightforward administrative fix. And then the fourth one too is that there's some states that are small. We, in the House version of the Affordable Care Act that didn't get enacted, had a national exchange primarily to have a large stable risk pool. You could imagine, and it's allowed actually under Section 10332, that you could do multi-state exchanges. It might make sense for a bunch of states to do that. The last thing, of course, there's a mandate. We had lots of debate over how high the mandate should be. Massachusetts' data was fascinating in that a very low mandate seemed to work well in Massachusetts, so the CBO had a lot of confidence that a low mandate would work. In other places in the country, it's probable that a higher mandate would have gotten more people in. And so Congress could think about that, although politically I think there's no chance they're going to think about it. All right, hospital market power. I mentioned 3 times that health insurance is expensive. It's expensive because hospitals are really expensive. The biggest driver of healthcare costs is the fact that people get a lot of service from a lot of people and in places where it's expensive. The single most expensive place to get care in America is in a hospital. The average price of a hospital day in America is about $6,000 now. It's amazing, $6,000. Like, I don't know a Four Seasons on the earth that costs that much. Like, I'll come to your house for $5,000 and I'll titrate your medications there and do it. Like, it's an amazingly expensive thing, right? And we use a lot of it. Over the last several years, we've seen hospitals get bigger. They've generally been employing doctors, both by acquiring practices and hiring more of them. Many have built large networks of primary care doctors, and in some places, too, they've also bought up many of the scarce specialists, which has made them must-have in every payer network. So if you're a health plan going to build your network in any major city now, you need to have adequacy of specialists and primary care doctors and beds and things. And in many markets, like, all the pediatric neurosurgeons work at one institution, so you got to have them in the network. And then they say, and now you have to have everything else in the network. Shockingly, one of the things I discovered is that a third of hospitals have gag clauses with health plans that require them to be always most favored, as well as not disclose quality information, which is, startling too if you want to have a market-based healthcare system. And then the last thing that's happened is that while I've written papers about how hospitals lose money on an operating basis when they hire doctors, because doctors, when they get guaranteed salaries, see fewer patients, it's offset by the fact that they can raise prices. And there's some great work done by Lauren and Jamie Robinson and a bunch of others who are heroes in this literature. Zach Cooper at Yale is another one, where you look at what happens to prices. And one thing that happens is prices go up. And they go up a lot. And so there's a 30 to 50% delta in markets where there's hospital market power versus not. And as important, the prices go up faster in markets where there's hospital concentrations. There's been lots of sensational examples of health plans and hospitals going to war and canceling contracts with each other over these price increases, and governors, like in the case of UPMC, that intervened to sort of arbitrate the contracts. But what you're seeing in hospital prices is CAGRs of between 6 and 9% nationally, which is higher than any other prices in the economy are going up. And while we talk a lot about drug prices, there's so much more spending in the hospital. This is the area of premiums and pricing where you need to worry, I think, the most. So what do you do about it? Well, there's 5 things that you could do. They all work well. They're all going to be unpopular. The first one is hospitals who have been both consolidating with each other and acquiring doctors have generally led with to the Federal Trade Commission that this is done for quality, that we're doing this because it makes sense for the patient, right? Have them in one organization where you can seamlessly walk down the hallway to the specialist and have them consult on a case, have your behavioral health care providers actually embedded in the practices to do chronic care coordination. Sorry, Dina, I butchered that. Be able to share data seamlessly across your convoluted Epic system, even within your own health system. And build products that really work well to serve the needs of complex patients. And that does make sense. And there's great examples of that being done in America, whether it's you take Geisinger, in Danville, Pennsylvania, or Kaiser in our backyard. There's examples that you can get value out of integration. The other hitch, though, is that the tendency will be to raise prices. And so one of the policies that we have considered is should there be a threshold above which you take all payer rates, or you make the hospital take Medicare rates for commercial patients, which would allow them to do the benefits of quality but not use the price lever. The state of Maryland pioneered this with all payer rate setting. So in Maryland, Medicaid, Medicare, and commercial pay the same prices. So if you're at Johns Hopkins, they love you equally no matter what your payer is. And so it's an interesting dynamic to think about, would you have as much consolidation if you couldn't use prices as the way to fund it? The second thing is, and this is particularly important for ACOs or risk-based doctors, is that when the hospital owns the specialist and they do testing, what had been one bill before, sending a patient to a cardiologist, turns into 2 bills, which is a cardiologist bill and a facility fee. This can add 20 or 30% onto the cost of care. And if you're in risk, that can be a real killer, particularly in markets where there's no option but to send them to a hospital-based physician group. And so site-neutral payments is an idea that MedPAC's promulgated for many years, and CMS is beginning to wonder about. Perhaps it would make sense. A third one is 340B pricing for drugs. 340B drugs are inexpensive and useful, and they can today only be delivered in hospital settings. It doesn't make a lot of sense because we want to move towards less hospitals. A fourth is for antitrust. Today, antitrust use these large regions called hospital referral regions, which are much larger than the circles around which patients drive to get care. When we looked in the Medicare data for what's the radius that a patient uses for their actual care, about 80% of them use a 5-mile circle, and they get all their care in a 5-mile circle. HRRs are like 50-mile circles, and so it's not the right unit to do competition-based evaluation. Then the fifth one is that all these mergers that we've reviewed and approved over the last 5 years have this big section about the quality benefits that will accrue by virtue of them being approved, yet nobody ever goes back and sort of says, well, did it happen? And there's no sort of penalty if they don't. And so we need to have some mechanism to sort of go back and say, like, are we getting the benefit of these things? So these are 5 policies that I think you're going to hear more about, actually, over the years to come, and ones that MedPAC's beginning to take up and Medicare's beginning to talk about. CMMI is going to test some of these, and so I'm hopeful that we'll see some of them enacted. All right, now to the good part, MACRA. So MACRA is the coolest bill because Congress passed it. It's the only bipartisan bill that Congress passed this session period. All right, it is the entire accomplishment of this Congress, and it got rid of SGR. And SGR, for those of you that remember, was a terrible idea, which was initially that doctors would self-regulate and lower the rate at which they do more activity, such that we would have healthcare cost control. It was part of BBA 1996. Bill Thomas said it was going to work. It didn't. 3 years later, after it didn't work at all, under BIPA, which was like the refinement of BBA 96, they passed a thing called the SGR formula in Congress, which said, okay, if you can't figure it out, doctors, Medicare will just enact an automatic cut to your payments. And each year the AMA went back to Medicare and said, like, we almost got it figured out. Like, just give us another year. And so we kept kicking that can down the road until I got into government, when every fall there would be a stat email out from the AMA to every doctor saying, warning, Medicare is about to cut your payments by 22%, 23%, 24%. It went up every year. Call Congress now to stop, Medicare from cutting your pay. And lo and behold, it was like every October 1st, about 50,000 letters came into Congress from doctors saying, don't cut my pay. Now, of course, they're not going to cut your pay. But that meant that people at the White House and at Treasury and at OMB and at the Senate Finance Committee then spent November trying to every year find the offsets to pay for the extra wages to doctors that weren't in the budget. And my job for 2 years was to go find offsets. And it was getting to the point where it was ridiculous, like $30 billion of offsets you have to find in a couple weeks. So we froze federal wages for 5 years. We did all kinds of crazy stuff to pay for this. It made no sense because it was kooky, because every year we'd threaten to do it and we never would. And sometimes Medicare would for like 6 weeks, but then they'd retroactively pay you back. Like, it was just a total disaster. Congress got rid of it, and they got rid of it with a bill called MACRA, which said to doctors the following. In 2019, you have an existential choice. You can stay in fee-for-service that you've been in forever for the rest of your life if you like, but it's not going to grow. It's going to grow at 50 basis points a year, which is less than inflation, and that line just goes to nowhere. Or you can go into a new and improved alternative payment model for a 5% bonus and then payments that go up in medical inflation. And so over time, it doesn't take an economist to figure out that it's better to be in the one that pays you more. And doctors respond more quickly to, one of the lessons is physicians respond more quickly to incentives than you might expect. So interestingly, in ACOs, you see practices change their behavior in 90 days. When we cut radiology reimbursement, you see radiology utilization go up in 6 months. When you change coding rules, hospitals can code the new rules like in 4 minutes. So, and so doctors respond to incentives, and MACRA is a big incentive to go into a new payment model. Medicare today released the rule, and the highlights of the rule are the following. There's downside protection for independent doctors. So if you want to go into a two-sided model, you're no longer on the hook for all of your Medicare, for all the Medicare spending a patient might have. You're only on the hook for the Medicare spending that you actually get. And so that's a great protection. You can aggregate yourself up into virtual groups as opposed to employed groups and do that for your quality reporting under MIPS, which is an administrative simplification that totally makes sense. There's an extra phase-in year. It's been made a lot easier, actually, for doctors to go into it. There's a lot of efforts around administrative simplification, around which metrics you have to report. It's a better rule than people expected, I think, is the general reaction. What's interesting here is that the quality bonuses that are in MACRA are not like the old-fashioned pay-for-performance 1 or 2% plus minus. It's like 27% upside. I mean, it is meaningful payments to doctors who do hit quality measurements. And so now we're going to see it play out. And I think it's going to play out in 2 rounds. That's Muhammad Ali for those of you that are like, my pictures will date me because you're going to be like, the Stanford at least student here will be like, what is this? This is called boxing. Um, Today we do it in a cage. So the first round is hospitals versus physicians, and who is the nidus of control in markets. And it's varying a lot based upon where you are in the country. So in California, we've had large physician groups who have had a lot of control and a lot of market power. That's unusual in the country. In most places, the hospitals have had much more control. And the second one, which I'm like reveling in and enjoying and predicting will be awesome to watch, but just beginning, is the amazing war that will occur between primary care doctors and specialists over who gets the money. So in shared savings, what's awesome about this is that we tell the doctor or whoever's managing risk, there's a benchmark or a budget for each patient. And in Medicare, it's often about $9,000 a year. And you sort of say, $9,000, anything less than that value can be kept by somebody. But that value is coming out of the income, the revenue, to either a hospital, a specialist, or a post-acute facility, and so, or a drug company. And so somebody's like losing in this game. And the easiest place to save the money today is to take a couple bed days out, so take it out of the hospital, and take it out of specialty referrals and diagnostic testing. Then sure, you'll take some out of the post-acute. And so you're lowering the incomes of people downstream, and you're creating a pool. And the primary care doctors want to say, well, I just did all these great things. I hired a care coordinator. I'm doing population health management. I see patients 7 days a week. I did shared decision making for the first time. The patient adhered to their medications, and we did it. Like pay me. And I even treated AFib myself. You're feeling you're feeling great. And so you create this pot of money. And interestingly, PCPs then say, like, great, I can be like Bob Margolis and like buy an airplane and become rich and sell my business and like, this is awesome. But the specialists say, I was so awesome not to cath your patient. You should pay me for that. And the ER doctors are like, I didn't admit them. I called you, like, pay me for that. And so there's this great fight over who gets the money that we're going to see play out that is going to literally yank at the org structures and hierarchies of health systems in a way that is going to be awesome to watch. Here's what's happened so far. So of the money, now I'm not asking for the audience to tell me how much the ACO program saved. I know it will save more in the future. It didn't like kill it yet. But of the money saved, half of it was saved by primary care doctor owned ACO groups. So they've done better. So when the PCPs are getting all the money and controlling it, they've saved more money than the hospital-centric ones and the payer-centric ones. This is an example from a paper we recently published that looked at the results from a couple ACOs at how much it lowered. I'm sorry, you can't read it. But it's basically, here's the takeaway. Specialist incomes go down a bunch when the primary care doctors make a lot more money. And so these are meaningful changes to radiologist income and cardiology incomes in real life that are occurring today in shared savings models that are surprising to the specialists. And that's leading primary care doctors to say, I deserve to be paid like the point guard or the quarterback, use your sports analogy that you like, that I am. I want $600,000 salaries. I want the specialist to work for me. And you can imagine that creates real tension in places that have a lot of specialists, right? And the problem is that that's fundamentally going to tear at the fabric of these large hospital-employed physician groups and integrated physician organizations. So to make this all work as they fight, we should do 5 things, I believe, to kind of make the choose. Right now, there's a lot of complaints about you have to go in 2 different directions. You have fee-for-service, particularly in commercial insurance that drives most of your margin, and Medicare doing all this other stuff. How do you sort of get to the destination faster? And there's 5 things. One is require movement over some time period of certainty to 2-sided risk. Because one-sided risk doesn't actually motivate a healthcare industrial complex to actually behave differently enough. And so have a time to go to 2-sided. Today, you don't have to do that. Number 2, is cap the losses at 100% of Medicare revenue. That's important because reinsurance is very expensive if you don't have a balance sheet. And so that makes it a lot easier for groups to actually manage the risk. Number 3, one of the flaws of ACOs is that you have to keep beating yourself. And we all have sort of a genetic potential at which we cannot do any better. And in the first 3 years, I think you can't argue that people can't perform better than they have in the past. But after the next 3 years, these resets reset to wherever you perform to. And so it makes the highest performing groups continuously have to beat themselves. And so you need to move to a regional benchmark. And Medicare, I think, has that in the rule. I have not finished that section. The fourth thing is bundle more revenue for providers. But you could also read this as align the payment methodologies, particularly across commercial insurance. So while I love the Medicare rules and regs and esoterica, the money's made in commercial insurance for most providers. And interestingly, despite rhetoric from commercial health plans, which are all talking about moving to value, blah, 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 when you go ask a commercial plan for a contract, what you get is we've never done that before, it was gonna take us like 2 years. And so having some mechanism to get the commercial and Medicare contracts more aligned, and then the quality measurement, by the way, in every one of these is different. So getting, again, simplification of these contracts so that they're more similar between commercial and Medicare is particularly important. And the last thing is, this is a real story. A hospital that one of our ACOs admitted a bunch of patients to, astonishingly quickly, changed coding. Patients who would come in with urinary tract infections and pneumonia and coded them all as sepsis. Interestingly, they were all blood culture negative sepsis. And so we discovered this because the practice had a very good data scientist who began seeing, wow, our $13,000 admissions just all became $45,000 admissions. What's going on here? And he called the CDC and said, there's an outbreak of sepsis in this small town in a state on the East Coast. You need to come and investigate. He used to work there. And so the CDC flew up and went into the hospital and said, we're here to protect patients. We want to quarantine the sepsis area. And it turned out all the blood cultures were negative. And it turned out that Cerner pushed out a coding update that allowed everything to get recoded as sepsis. And so it's extraordinary how quickly this happens. And Medicare every year in a cat and mouse game, tit for tat back against the providers with something called the coding intensity adjustment. I had to define it for 2 years in a row. It's basically how you counter upcoding. And it's about 70 basis points of Medicare cuts each year in the Medicare Advantage program for coding. But we have much more than 70 basis points of upcoding a year. And so you need to do something to balance that, or we're going to have this sort of problem of a bunch of shared savings occurs and then it's all given back in coding to the providers, in my opinion. All right, how do we save more money faster? And I know you're getting anxious. I'll finish soon. There are 8 things that if we were courageous, we would do tomorrow. Labor productivity is the thing we most have to do. Medical malpractice is something that we need to do. And there's a bunch of other stuff that would make a heck of a lot of sense, and I'm not going to go into all of them for the interest of time. But this is my favorite chart in U.S. healthcare, and Doug knows that I show it every time, and Rob does too. Last month, we made 33,000 new healthcare jobs in America. That is terrible news, because we've made about that many jobs every month forever. Since the beginning of the Bureau of Labor Statistics, we made that many jobs in healthcare. During the recession, in every quarter, the red is the job losses in America, the white is healthcare job growth. Demand for everything in the economy fell, healthcare jobs grew. We had 50 million more uninsured people, healthcare jobs grew. We had a recovery, healthcare jobs are growing. We didn't have coverage expansion until 2014, but healthcare jobs grew. Healthcare jobs are growing every quarter, and that's awesome because they're high-quality middle-class jobs with benefits, and it's a nice place to work. But labor is really expensive, and if you take our $3.3 trillion and cut it another way, and 2/3 of it's wages to workers, and in every other sector, we've squeezed down the labor of administrative labor to have less non-value-added workers and a kiosk that you check yourself in on. Healthcare hasn't figured that out yet. What's awesome is that we know that technology can do it. It's done it in every other sector of the U.S. economy, save education and defense. We need to see it happen in healthcare. Today I spend most of my days trying to make little attackers to go chip away at that waste and use technology to do it. And I would say one good news is that there's been $10 billion more venture capital going into early stage healthcare over the last 5 years, and 10,000 new Series A companies created, so that's great. But we need like 100,000 more. There's just so much more work to do to get productivity unleashed in the sector. I want to leave you with 4 things. I believe actually that the ACA is working better than expected by virtue of the fact that there's nobody in the ecosystem that's not behaving differently. Whether you're a large employer who suddenly is trying to engage your employees and use point solutions to get them to act differently in how they consume healthcare, make people aware of cost and quality. Whether you're a health plan who's existentially worried about member engagement and churn for the first time and not able to use underwriting as their major source of power. And new entrants even into the health plan space, whether it's Bright Health or Oscar. Hospitals who increasingly, while they have been employing more doctors and raising prices, have also been adopting technology, liberating their data, using startups to try to redefine both care and the experience of care, embracing telemedicine. There's lots of things that are happening on the delivery side. And then finally, for patients, I mean, for the first time, you see patients begin to engage with new technologies to do care, and doctors willing to enter new payment models. And so we're seeing distress and I think joy creation across the entire ecosystem as we explore how to make it work better. The second thing is that the ACA can be made better, but I think the policy things that I spoke about earlier are things that A, don't cost a lot of money, B, when you put Republicans in a room and point out that they passed them all under Part D and MA, which are programs that they like, it's not that hard to imagine that it would be okay here. The technology will strip out a bunch of costs. One of the most fun parts of my job as a venture capitalist, I get to see a lot of these embryonic ideas, and many of them have powerful ways to pull cost out and improve quality. And so I'm hopeful that we're going to see much more adoption. And then finally, it's going to make it better for us. I mean, being a patient completely stinks, and it will be a lot better sooner because we'll have technology and organization and coordinated care and data that helps guide the care. So I'm more hopeful than ever about being a patient. So with that, I'll stop and thank you and invite questions.